Well, I'd like to welcome you all here today. My name is Denise Miller. I am a community program coordinator with the Canadian Mental Health Association of New Brunswick. And my co-worker, Corey, is on here also, Corey Ferguson. She'll be monitoring the chat and that kind of thing and just kind of answer any questions you guys may have. She's the one that's very kindly posting to everybody. There's some links that she's put on there, some helplines and all kinds of stuff, our website and everything else. So today we're going to talk about understanding challenging behaviors. This presentation was originally created by a registered nurse by the name of Brenda Bell with the Addictions and Mental Health Unit. And she very kindly gave us the presentation to be able to be there and to be able to deliver it to the general public. So we're really thankful to her for that generosity, and we'll go ahead and get started. Okay, so what does the Canadian Mental Health Association of New Brunswick look like in this province or in Canada in general? So we were founded nationally as an organization, a national charity in 1918, which makes us just over 100 years old. And we've come together to help maintain and improve mental health for all Canadians. All right, so, and then of course in this province, we're a leader and champion for mental health. CMHA of New Brunswick helps people access the community resources that they need to build their resilience and support them in recovery from mental illness. So CMHA of New Brunswick, what do we look like in the province? We have 18 locations throughout the whole province, so no matter where you are, we've got you covered. We have 3 offices in the province. Our provincial office is in Fredericton, and then we have an office in Moncton and one in St. John. And the offices most of the offices are run by community program coordinators, of which I'm one. I think we're 14 in total in the province. So there's one in the Fredericton office, Corey's in the Fredericton office, we have one in Moncton, one in St. John, and the rest of us are all rural areas. So we cover the whole province, and that's just amazing. We have a provincial peer support program, which is tied in with our FACT teams throughout the province, and they're there to help navigate the system, help people navigate the system. And we also have an employment program called Working Stronger Together, which is based in Charlotte County, and for people in that area to help them either return to work or to get work, to obtain a job. And they help with job sharing, preparing of resumes, all kinds of great stuff. We're hoping someday to be able to expand that program throughout the province, but it takes funding. So that might be a little bit before we can get there. Okay, next slide, please. All right, so understanding dementia. Dementia describes a group of symptoms affecting memory, thinking, and social abilities severe enough to interfere with daily life. So it can be caused by damage to or loss of nerve cells and their connections in the brain. And then depending on the area of the brain that is affected by the damage, dementia can affect people differently and cause different symptoms. So memory loss, which is usually noticed by a spouse or someone close to the person, and most often it's short-term memory, which can make a person repeat questions or stories or misplace things. People with dementia often have relatively good long-term memory, remembering things from many years ago. So they'll have difficulty communicating. They may forget simple words or substitute words, which can make it difficult when you're trying to understand what they're saying. They can have difficulty with visual and spatial abilities, such as getting lost while driving. They can have impaired judgment, so they may not recognize a medical problem that needs attention or wear clothing on a hot day, like too much clothing, heavy clothing on a hot day, and then may dress cool for a cool day. So they have difficulty completing tasks that have been familiar to them. Examples are preparing a meal or playing a game. Difficulty with planning and organizing. They may need assistance paying bills, ensuring correct medications, that kind of thing. Difficulty with coordination and motor functions, and change in personality. They can become suspicious, confused or withdrawn, have a lack of interest, fearfulness, or just acting out of character. Next slide, please. So behavioral symptoms of depression, dementia, sorry. Behavioral ones based on observing the individual, we'll see agitation, screaming, restlessness. You'll see them, you'll find that they're often agitated. They can't stop moving, and they're fidgeting, and they're constantly, on the go, screaming. There's a lot of screaming and high a voice that's risen. Restlessness to them, and that goes in with the agitation. It seems like they can't settle down. They'll wander a lot. My sister-in-law, who was diagnosed with early onset dementia, she's a wanderer. She'll wander around and around. Sexual inhibition. Goodness gracious, I had trouble saying that. And cursing. So you'll find a lot of that, that agitation, the wandering, the restlessness, the cursing, the screaming. Like there's a lot of that. It's almost an aggressive behavior coming out of them. The next slide, please. Psychological symptoms, anxiety, where they'll deal with apprehension and tension, panic or worry. With depression, there's a loss of interest in things that they used to really enjoy, and they'll have a low mood. Hallucinations, they may see a person or an animal that's actually not present, but they truly believe in their reality they're seeing that there, right? In delusions, false beliefs are strongly held. Suspiciousness, abandonment, and misidentification. An example could be convinced that the spouse is unfaithful. People are coming into the home and hiding, stealing things, right? So those delusions are there, and they're imagining these things, but again, in their reality, they're real to them. And then apathy, diminished interest, slowing and lack of energy, unease, and just really dissatisfied with life. So they're really struggling a lot. Next slide, please. So with dementia, we'll see personality changes up to 90% of the time. Their personalities will change. Affective changes. Depression will be prevalent in up to 80% of the cases, and people will deal with mania 15% of the time. So behavioral changes, agitated behavior is up to 50% of the time, and aggression up to 20% of the time. So that's kind of what it looks like if we're just kind of looking in and seeing those kinds of changes, personality-wise, affective-wise, and then behaviorally. Next slide, please. All right, so common causes of challenging behaviors is misinterpretation. So in the environment, if we want to look at, where these behaviors are coming from, sometimes we need to look at what's happening in their environment. So what's changed in their environment? Is there a new blanket, or did somebody move a chair, for an example? Have they been moved to a new environment? Have they been moved bedrooms, and now they're very confused? For the caregiver, is it a new caregiver that's taking care of them? Was it the way that the caregiver approached them? Maybe they did it too abruptly, right? So an example is that a new nurse visited a patient, and he became very agitated. And it turns out that they learned she looked just like his ex-wife, so a switch of nurse was made. Signals and cues. Often signals or cues to assist, like pointing, gesturing, demonstrating, or guiding, can be very helpful. So medical causes can increase confusion. Be aware that any infection, for example, urinary tract infection, can cause delirium in the elderly. And pain, which is bone, dental or oral, skin, breakdown, and rash. So pressure also from not weight shifting is limited if limited mobility. Personal hygiene, not brushing their teeth properly, causing pain. Not washing properly, leading to a breakdown in the skin, causing a rash or ulcer pain, right? So we want to be more aware of that kind of thing. Um, and I can remember when I worked in Ontario, I had worked with a behaviorist, a gentleman who studied behavior. And I worked very closely with him for almost 7 years. And one of the greatest tools that he ever taught me was an ABC chart, which was A for antecedent, B for behavior, and C for consequence. And he said, often when we're trying to deal with a behavior, change a behavior, eliminate a behavior, that kind of thing, we wait for the behavior to happen and then we do a consequence. But he said, in this case, why not look at the antecedent? What happened just before the behavior? Because sometimes when you deal with that, then the behavior never happens anymore. So it really is a matter of being an investigator. We want to look, what is causing some of these challenging behaviors? They're coming from somewhere. Is it the environment? Is it the caregiver? Is it signals or cues? Are we saying their name first, face to face, when we want their attention to try to talk to them and give them a direction? You know, things like that. Next slide, please. So common causes of challenging behaviors: fear, being in a constant state of anxiety and uncertainty. Day-to-day things become more and more stressful, and it creates an awful lot of doubt. Okay, the anxiety really gets pretty big for them. Fatigue, the body tires more easily. They're constantly in a state of anxiety, making a person tired as well. If you've ever experienced anxiety, and I'm not saying anxiety is an illness, but we all experience anxiety sometimes on a day-to-day basis. It could be a phone call that we're waiting for. It could be, some event or situation that's happening that's creating some anxiety in you. And we know how that feels within us emotionally, mentally, and physically. So imagine living with that all the time. It would become very tiring, very tiring. Boredom is another area. Loss of executive functioning skills. So they don't remember how to make a cup of tea anymore. They don't know how to clean the fridge. They can't remember how to prepare a meal or to plan their own day. And loss of these skills leaves a person bored. They have nothing to do. There's nothing for them to do, physically do, to get up and move and do something. They forget how, and it makes it very difficult. The number one cause of aggression towards their caregivers is usually involved in intimate care. So the bathing, the toileting, the dressing, and the feeding. Imagine yourself requiring someone to help you with those intimate details. It'd be very humbling. It would be, I can remember back when I had carpal tunnel surgery. There was a lot I couldn't do for myself, and I had to have others help. And it was very difficult for me to accept that type of help. I would think it would be like that for pretty well everybody. Next slide, please. So, resistance versus aggression. Well, resistance is an attempt to protect the self from harm, and in cognitive impairment may be an instinctual reaction to not understanding the environmental and expectations. It implies that there's a defensive action, and resistance must be in relation to an action. For aggression, behaviors that are angry and destructive and are intended to be injurious physically or emotionally and aimed at domination implies offensive action, and aggression can occur without provocation. So they'll resist because something has created that. So there's some situation that's created that resistance, that's bringing that out. In aggression, it can just come spontaneously. There doesn't have to be a reason behind it. Next slide, please. So can we prevent challenging behaviors? Behavioral problems are often triggered by unmet needs and a lack of understanding of the individual with dementia. Gathering information about the person whom you are caring for, treating, can be vital in understanding, preventing, and ultimately treating behavioral problems that may occur in the context of their illness. So unmet needs could be anything from being bored, in pain, lonely, hungry, or even uncomfortable. Knowing as much as we can about the individual helps us in that provision of care, in deducing, supporting, and so on. So the more information that we can have about our patient or our loved one, the more knowledge, the better it will be, and perhaps hopefully a little easier it'll be to take care of them. If you're a regular caregiver and someone comes in to relieve you, give them as much detail as you can to help in the caregiving process, even down to details of if they had a bowel movement that day. Like, that's very important information to have. So an example, when I would babysit for my niece, and she had a chart of information regarding her children. This made our time together go a lot smoother, and it gave me the confidence in providing that care because I had information on each child. This one likes this, I have to have his sippy cup and his blanket when he goes to bed. This one wants nothing but wants a light left on. This one wants nothing at all, total blackness, shut the door. It gives you that understanding so that you can keep that similarity going, which is really important. Next slide, please. So, questions to ask. When we want to do an assessment of challenging behavior, what are the kinds of questions that we would ask? Well, we would look at what specifically is the problem. So make sure that we're not catastrophizing it, we're not blowing it out of proportion, we are looking specifically at the problem itself. And so why is it a problem now? So perhaps 2 months ago, it wasn't an issue, but it started up about a month and a half ago, and it started becoming an issue, and now it's an actual problem. So why is it that that's happened like now? Like, what is it that caused that to start happening? Who does the problem affect? Does it affect the caregiver? Does it affect the patient? Does it affect loved ones? Who is it that is being affected by that problem? And then, of course, is there a safety risk? Is there a safety risk to anyone, including the patient, with this particular challenging behavior? Next slide, please. So when we look at why is it a problem now, we want to know, is it new? Is it a recurrence of an old behavior previously under control? Is it of increased frequency or severity? Is there something or someone new on the scene? Perhaps a new caregiver, right? Has something else changed? Sometimes it can be a very tiny change, something we may not even have noticed, but they've noticed, and it's causing some agitation for them because it's not similar. It's not routine for them, right? Next slide, please. So with assessment, further questions could be, who does the problem affect? So is the behavior problematic for the individual? Does it cause them stress? Does it cause them annoyance? Does it bring about a screaming? What is happening? Is it that they can't communicate anymore with their caregiver because that is affecting them to that degree? Is the behavior endangering, irritating, or upsetting to others? Perhaps it's in a home setting. Is it affecting other clients that are living in that home, other people living in that home? Does the behavior upset staff or interfere with care? And if so, does it happen on all shifts, with all staff, just one staff, just women, just men, only at bath time? So we really, really, really want to get as specific as we can in regards to the problem. So where it's come from, who is it affecting, and then really trying to get a really good idea of it. Next slide, please. So when we're addressing behaviors, general approach to new and upsetting behaviors, we want to look for underlying causes. So it could be something of unmet needs. So something in regards to toileting, hunger, thirst, their bed, their clothing, their meals. It could be, one of many things, or one thing in particular that's there's an issue with it. It could be that they're living with pain, a new type of pain that's now happening, and of course it's not being treated. So they have that pain is there, and then they can't tell you. Constipation. The bowel movements are very, very important, and if things slow down to that much of a degree and that patient becomes constipated, it's going to cause them some distress for sure. Treat underlying causes. So what we want to do is we want to make sure that we're looking to try to figure out what the underlying causes are, and then we want to deal with those, right? So what's the antecedent that's bringing on those new behaviors? And so let's deal with whatever it is that's happening, and then hopefully it will create an ease in those behaviors. Next slide, please. So addressing behaviors. Well, the general approach to new and upsetting behaviors is be aware of the person's functional abilities. So you want to check your communication style. You want to speak slowly, clearly, and respectfully. Use simple instructions one step at a time. For example, say their name first, okay? It might be, Denise, can you pick up the washcloth? Okay, so say their name, get their attention, and then use clear, simple instructions, and just one step at a time. Watch your body language and their body language. We can read so much into body language. Be careful on your perception of their body language, but be certainly aware of your own and how they may be perceiving it. Learn all you can about dementia and specifically about how it affects this person. Remember to use their hearing aids and glasses if they use them. That's very helpful, and that certainly could be a cause for agitation on their part. So example would be ensure that you approach them from the front, not abruptly coming upon and starting to wash their face. Okay. Showing them the face cloth, the wash basin, pretending to wash your face, and then inviting them to be washed. So we want to allow whatever functional abilities and skills that they have, we want to encourage them to keep using them. And it may take time, and it may, it may take repetition. You have to repeat over and over and over how to do it, but it's so important to allow them to keep doing that as long as they can. Next slide, please. So top behavioral problems not responsive to medications. Well, wandering is a big one. They'll wander. They have no idea that they're leaving the building and they're going outside and they're heading off in another direction. So it's extremely important that we keep an eye on them. Inappropriate urination and defecation. Inappropriate dressing and undressing. Frequent repetition. Hiding and hoarding things. Eating inedibles. Annoying activities such as pulling on locked doors, etc. They'll stand there and they'll just keep pulling on that door trying to get it open, not understanding why it doesn't want to open. So these kinds of behaviors are not responsive to medications. Okay? Medication will not help with these types of behaviors. Next slide, please. So specific challenges, repetitive questions, for an example, could be, where's my wife? What do I do now? Constantly ignoring repeated questions works for some. Distraction with food, presence, and activity. React and respond to the emotional content rather than the words. A controversy over therapeutic use of lies. So, distract him or her with other things or activities that you know he or she likes or values. Redirect his or her attention and actions to something that is okay. Look concerned, not too happy if the person is upset. Use positive, friendly approval or praise. Use touch, hugging, hand-holding, comforting only if the person wants it. We want it to be supportive, not confrontational. So therapeutic use of lies. A lie with a positive outcome. Legislation and policy forbid lying to people in care, stating that nurses must be honest and trustworthy. However, when caring for people living with dementia, there are times when perhaps honesty would in fact cause more harm than good. People living with dementia often communicate in ways we as caregivers find difficult to understand. Rather than using straightforward sentences, an unmet need is often communicated through repetitive movements, questions, a change in mood, or physical action. So when a person living with dementia is asking for their mom, their dad, their children, or to go home, step back and think, what are they really asking for? Often it's not the specific person or thing, but communicating an unmet emotional need. For an example, where is my mom? Possibly wanting to feel loved and comforted. Spend time with them, ask them about their mom, look at a picture. This can help bring back happy memories rather than trying to avoid talking about her, which may add further anxiety as well as help them to feel comforted and connected. Therefore, you're not masking the problem with a lie. Instead, you are treating the root problem. Next slide, please. So challenges, verbal and physical aggression. Try to intervene early. Before it escalates too far, try to intervene. Try to avoid situations that are known to be provoking for the individual. So perhaps it's a particular situation, like music might irritate them. They might not like noise. So if you know that there's going to be a music session from 2 to 3:30 that afternoon in the main hall or next door or whatever, we want to make sure we try to remove them from where that noise is going to be. Use a calm and reassuring voice. Avoid arguing or confronting when agitated. Allow them just to be. We don't want to confront or argue with them, don't want to find ourselves in that situation. Approach slowly and always from the front. You come up from behind you, you're going to startle them, you're going to scare them. They may feel that the anxiety is, oh my God, they're here to hurt me. They may not understand. So it's always important to circle around and come at them from the front so they can see you coming. Next slide, please, Corey. Thank you. Challenges, verbal and physical aggression. Use touch judiciously. It can be perceived as comforting or provoking. Use a non-threatening stance, and you should be at eye level. So in other words, if they're sitting down, then bend down. One knee on the floor, bend down so that you're looking at them eye to eye. Use distraction, right? Oh, have you seen these pretty flowers? Aren't they lovely? Can we smell the flowers? Right? Next slide, please. So sexual inappropriate behavior, verbal requests for sex. If caused by dementia, usually caused by a deterioration of the frontal lobe, which regulates socially appropriate behavior and impulse control. It's not very amenable to change in the later stages of dementia. Staff can firmly say no, try a distraction, or other techniques depending on the level of cognitive impairment, premorbid personality, and staff's own comfort. So staff response and attitudes are often the focus of the treatment. So again, we want to make sure that everybody's comfortable with it, but we also want to be, trying to be firm with saying no and then distracting them. Next slide, please. So the top 10 problems that may be responsive to medications, So medications may help. Physical aggression, elation, pressured speech, and hyperactivity, delusions and paranoia, hallucinations, sexually inappropriate behavior, anxiety and restlessness, sadness, crying, and insomnia, withdrawn, apathetic behavior, regressed behavior, and verbal aggression. Next slide, please. Okay. So I have an extra slide here in my notes, and it talks about caregiving for the caregiver. So I'm just going to review these with you because I think they're really, really important. So self-care is extremely important for caregivers, extremely important. Caregivers often think that they can and should handle everything alone. The best way to avoid burnout is to have the practical and emotional support of other people. So in other words, build a support system around you. I have two parents that are still living. They're both in their 80s and they're doing very well. And I drop in at least once a week to see them. I often have them come out on the weekend to have supper. We'll play games, that kind of thing. I check in with them. But I'm not the only sibling. I have 3 other siblings that are close by. So between the 4 of us, we check in, we drop in, we get them out and we do different things. So we've built that support team around each other to be there for our parents. And the same idea is there for the caregiver. You need to build a support team of people around you to help you. So it's all right, Corey. So the person with dementia needs to be a healthy care partner. An effective partnership depends on the physical and emotional well-being of both of you. So it's not only the well-being of the patient that we're looking for, or the person living with dementia. The caregiver needs to have a really good sense of emotional and physical well-being also. Take breaks. Nutrition is very important, good nutrition, right? Exercise, sleep, fresh air. Do something fun when you can, when you're off. Join a support group looking for that extra help and support in those conversations, Share your emotions with a trusted friend. And if you're experiencing difficult emotions and thoughts, seek out guidance of a therapist or a counselor. They become extremely important as you move forward through your caregiving. And remember, most of all, self-care is not selfish. It's imperative. Self-care, we cannot emphasize that enough. People need to start practicing self-care on a much more regular basis. And self-care can look at whatever it looks like for you to make you feel happier, more balanced, more secure, more comfortable. All those wonderful feelings, those good fuzzy feelings that we get. It's because we're taking care of ourselves. And when we take care of ourselves, we've got much more to give to others. So it's extremely important that we're looking at those kinds of things. So that is definitely the caregiver slide. And then there was one that was just a review, and it says, our understanding of cognitive impairment is vital to the care that we give to patients and their families affected by these illnesses. Our understanding of the person behind the illness makes understanding their particular presentation and their problem behaviors much easier to understand and work with. Some problems are really very simple, but become incredibly complicated by system issues, taking things personal, stigma, and lack of communication. So it's really, really important that we get all of that we understand all of that. And then our resources, we have the Alzheimer's Society of New Brunswick, and they have a toll-free number. If you're looking for it, it's 1-800-664-8411. There's also Horizon Health. They have online books on booklets on dementia. Of course, the family doctor can always be helpful to you too. Geriatric assessment clinics, your family, friends, respite care, local home care agencies, local mental health and addiction clinics. We have, I'm going to say, I think there's like 8 or 9 of them in the province. So they're there obviously to help you out. CHMO line is 1-800-667-5005. And then there's also 3 different websites. There's Huddle, HUDDOL.com. There's dementiafriends.ca, and there's alzheimer.ca. So again, those are websites that can certainly help you out and help you find information. So Corey has put on, very kindly has put on our email addresses. If you're looking for any information or you're wanting any of those numbers and that I was just reading off, please reach out to us, let us know. You could also, a great tool that the government has developed in this province with the help of United Way, we now have what's known as 211. Just like 911 and 811 and all of 411, we now have 211. And 211 will put you in touch with somebody who knows of all the different types of services, the support groups, the resources, everything that's around you in your community, depending on whatever topic it is you're looking for information for. And they can give you all that information. So you just need to pick up the phone and dial 211. Tell them where it is that you're living, in what area, and then what it is you're looking for information on, and they'll be able to help you with some guidance there. So, and there's their website, 211.ca. So you can even Google it and then find out the information that way. So are there any questions? Is there anything that anybody's wondering? Chandra, thank you. It was very nice of you. Yeah, the caregiver slide. Today's president, we've got to make sure we put gas in the gas tank. Yes, we do. We have to make sure that we're taking care of ourselves, right? We have to. That's a must. It's an absolute must. Okay, Karen, do you have a question that you wanted to ask?
Yes, one of the things you mentioned was about, the use of eyeglasses and hearing aids.
Yes.
I'm here today because my mom has issues, many of which you've talked about, and we're going through the diagnosis process, and she's getting geriatric assessment and so forth. I know that she has hearing loss, but my concern is that to get hearing aids, I'm not sure she has the ability to manage them. She is living independently with her husband. He is the main caregiver. He too has, some failings. And it's really, this is all very new to me. It's interesting because you're right. My mother doesn't even get up to get herself a cup of coffee, and I just don't understand that. But anyway, as it relates to the hearing aids, to start somebody on this process, I'm not sure I'm wondering now, when we moved here from Pennsylvania a year ago, here is British Columbia, actually Vancouver. And I know that's an issue, hearing, but now that I've been living and being around them regularly, I'm not sure about hearing aids. What do people do with people having this issue with hearing aids?
It may be something, Karen, that you may want to have her tested first of all and see if there is a hearing loss and how severe it is. My husband has had hearing issues since he was a young boy. We recently went in, and in one ear he is mild to moderate, but the other ear is profound hearing loss. So he's definitely wearing hearing aids now, especially for the right ear with the profound hearing loss. He literally couldn't hear anything anymore. But if anything, if you decide to not go with the hearing aids, as long as the caregivers and those involved understand, they may have to raise their voice, not scream at her, but to make sure if she's not complying, if she's not doing what she was asked to do, it could be just simply because she just didn't hear it, right? So again, we want to stand in front of her, have her attention so she's looking at us, we're standing fairly close, and we're speaking fairly loudly, with not just kind of a normal voice or a soft voice. We want to speak with a louder voice to make sure that she's understanding. But, that can certainly become an issue, and a person is not. I've often said my sister-in-law, she was diagnosed at 51 years of age with early onset dementia. And oftentimes, in talking with people that that we know and that are close to her, whatever, they'll say, oh, she was giving the caregivers a hard time the other day or whatever. And I'll say, you know what? She's not giving them a hard time. She's having a hard time.
I'll tell you, that's one of the things that, again, we're in the process of is determining, and we're literally going through these assessments now. The occupational therapist is coming in this Thursday to see what can be done to help. But I have been told fairly explicitly that if she doesn't accept, like if we set caregivers in place to
Right.
come visit to help her out, and she is not open to them coming and giving her the help that they're offered, they're not going to stand there and argue with her. They will leave. And one day I can talk to her and both of them, and they'll say, yes, we really can use some extra help. But the next day it's like they don't even remember I've talked about it. So I'm a little concerned about that.
Totally understand. I completely understand. We went through that with my father-in-law. We wanted to get help coming, and we thought at least to have somebody come in and cook his meals, because all he was making now was peanut butter and bologna sandwiches. In 2 pieces of bread, he'd have peanut butter and bologna. He loved it, and he said he was just fine, but we were concerned. He's not getting enough nutrition, not getting enough minerals and vitamins. Like peanut butter and bologna don't just cut it. They're not giving him everything he needs. But that's what he was eating 3 times a day. But he was adamant. And we had a lady, we explained to her, he may be very hesitant. He may get aggressive. He may not want you there at all. So we actually went in with her into the house, and he told her to leave. Like, he was not having that. So all we could do was, when we prepared suppers, we made sure that we made leftovers. We put them in containers, and we put them in the freezer.
I was using Meals on Wheels for them because my mother was always one that did the meal prep. Her husband is the one that has taken this on. He is having issues in that he couldn't take the prepared meals from the deep freeze. He just, for some reason, there is some issue for him. Poke a few holes, warm them up. He would keep the frozen meals in the fridge, which of course means the quality of what they're having deteriorates. Anyway, long story short, I had to stop that because we were just throwing food out. Yeah, food's a real issue for me, but anyway, that's another story. I just wanted to know about I thought about the hearing aids because she's never had them, and if we get them, I'm not sure that she's going to be able to follow the directions to use them, A, and B, I'm not so sure that she won't lose them because she puts things down and puts things away. And oh my gosh, I find her clothes in with his clothes and all kinds of things like that. So that's my concern about hearing aids.
Karen, I would really recommend or encourage you to check out like dementia.ca, alzheimer's.ca, all these, and see if they have ongoing support groups, and that you could become a member in the support group, and that what you're doing is you're hearing other people's journeys. Maybe somebody has a parent that's more advanced, and so they may be able to relate and give you some ideas and suggestions, the things you can try that worked for them, that was successful for them with their parent. So that could be really, really helpful. And then just having that support group around you is very helpful too. My heart goes out to you. I know what you're up against, and you just got to keep trying and trying and trying. But there just comes a point too. My father-in-law had always said, I was born on this farm, I lived my life on this farm, and I'll die here. And in the end, he died in a nursing home, and we had no choice. He was wandering. He would take off on us. He lived there alone. He wasn't eating right. There was no self-care whatsoever. No hygiene. It was we would go up to try to get him to shower or bath. There was no way we could get him to do it. And very, very stubborn. He didn't trust any of us anymore. This was a man that would give the shirt off his back to a total stranger. Complete reversal in personality. So it does get very, and it can actually get hurtful too, especially when the distrust came. I'm your daughter-in-law. I'm your biggest fan. I think you're the most important almost the most important person in my life. Like, you're right up there, the top 3. I love you so much. And you would think that I would actually try to do something to hurt you. Like, there was once it actually became personal, and I took it personally, and I was like, oh my God. And then my husband looked at me and went, Denise, what are you always telling us? It's the illness,
I
it's
am
not
totally,
him.
Denise, I am totally there right now. I'm looking,
Yeah,
they get really upset with me. And in fact, her husband said to my husband that he doesn't trust what I'm doing. And anyway,
exactly.
yeah, my gosh, Tony, she is doing everything. And
Yeah,
they thought that they moved here. We brought them up without giving them a lot of advance notice. I say we, meaning my sister and her husband, brought them up from Pennsylvania to here. So I know that change has a lot to do with this, that physical,
yes.
geographical change. And they swore they were going to be buried on the farm. And my gosh, didn't Tony, her husband, sell the farm unbeknownst to any of us? And then it all has just tumbled from there. Anyway, that's we're dealing with all of that. But I'm sorry, I'm just kind of
Don't
talking.
be sorry at all. Don't be sorry at all, because the challenges you're walking through could be very familiar for other people on this too. So, I mean, if they're still here, they're listening because they're interested. So don't be sorry for that. But I would strongly encourage any of you out there to try to connect with a support group, just to have that extra there, that, just somebody to randomly throw out a question, this is new. What do I do with this now? This is a new behavior for us. Do you think it's going to get worse? Will it maybe go away? And, so there'll be other people there that will be able to share and give you that support and everything that you're looking for.
This was great today. Thank you.
Thank you all so much for joining. Are there any other questions? Okay, William says, I think Karen's experience highlights the familial tension that often accompanies declines of this nature. Something that I've observed along my family is that care often falls to one person in particular, usually whoever is geographically closer. What suggestions do you have for family members living further away? Oh, totally get it. Totally get it. And really, that is technically what happens. I understand that very much. My father-in-law, when he got sick, was living in Ontario, and of course, we're in New Brunswick. His two sons had built their family homes on the family farm, so they were close by. And his only daughter was living in Ottawa, about 45 minutes away from the family farm. So what happened is the boys tended to do most of the self-care, or most of the care for their dad. And it was one in particular who really did it. And I would often say to him, because I would check in with him quite regularly, and I'd say, Ray, how's it going? And he'd say, oh, well, and he'd bring me up to date where his dad was and stuff like that. And I'd say, I just wish that we were closer so we could help. And he'd say, it's all right. It's all right. I'm doing okay for now. And he would just take it one day at a time. And I said, well, if there's anything that you can take from this, is that once your dad is no longer with you, you'll have all the memories. And that's going to be very important. And he's been passed now for 5 years. And my brother-in-law does speak quite fondly, and he'll chuckle now at some of the things that his dad used to do during his illness. Some things that at the time weren't necessarily funny or humorous, but can laugh about today. So it's hard. And that's where I talked about that, building that support system around you. So having a support group is very helpful. Having somebody else to lean on. If there's no siblings nearby, then is there someone, yeah, you have a lot of memories, yeah, that I pass on to my siblings. Exactly, by having provided that care, you were the one that was most often there. You have those memories and everything, and those are such a treasure. But building that support system around you can be extremely important, and it might be reaching out to a home care organization that might be able to have one constant person that can be there to relieve you. It might be looking at nephews and nieces that might be able to help you. What of the family group is there to support, and do you feel that much alone? So in a lot of caregiving situations, folks talk about the importance of the supporter having a support network. So if you can't support the loved one living with a diagnosis, how can you support those doing the caregiving emotionally, physically, financially, in terms of time, advocacy, and system navigation, etc. Nailed it, Denise. There you go. So Corey's agreeing with me, and by saying is building up that support network around you can be so important and so valuable. Do you have to do it all, or can you pass some of those responsibilities on to other people, to help you? That's that support system that you can build around you. So I would look to see what all your options are. Again, please reach out to support group, because people that have walked the walk and talked the talk are the ones that can give you some direction and give you some suggestions and ideas to work with, and be there to provide that support. I know that in Sackville, not far from where I live, for the community, the Tantramar region here in New Brunswick, they have what they call a Memories Cafe. And they all go, it's the person affected with dementia and a caregiver, a loved one, go and they sit and they have coffee and they talk about memories. They share memories and they talk about old times, and somebody will start telling a story about, when we had to feed, put coal in the furnace and to heat the house, or we had to get up in the middle of the night and throw some more logs on the fire and things like that to keep the warmth going. Or it's finding that support system. What are all those resources that are out there and around you? Bring into your situation. Try 211, see what they can tell you, what there are for support services and resources around you. So hopefully that helps. Barbara has her hand up.
Yeah, my dad's in a long-term care nursing home in Ontario, and I live in New Brunswick. He's been there now for probably a year and a half. I just wonder, every time they've arranged, I have a Zoom call with him every Saturday, which has been great. But first time I've seen him in over a year was on this Zoom call, so that's been really helpful. But he keeps asking every time I talk to him about, he has a fear that he says, I have nothing. He said, what do I do if they kick me out? And I said, I keep telling him, well, they can't do that, Dad, without talking to my sister lives near him. She's sort of the main contact, but they can't do that. And right now with the virus, he understands the virus, and he understands that there's something going on that's, preventing, I said, so you can't go anywhere right now. And he wants to leave. He says, I don't want to stay here after this year. He says, I want to leave here. Is there any way I can come to New Brunswick? And I handle it by saying, well, Dad, nobody can go anywhere right now.
Exactly.
And I said, where you are, you're safe. They've had no COVID in his nursing home in Ontario, believe it or not, which is great. So I said, you can't go anywhere right now. So I said, don't worry about that for now. And I said, well, so I'm sort of hoping that when the time comes, we'll just I just sort of keep putting him off and saying, well, if anything, COVID's at least given me an excuse to say, nobody, I said, I can't even leave New Brunswick yet, so you can't go anywhere right now, and you're in the safest place you can be. And so do I just sort of keep telling him that? I mean, that seems to make him, he understands, and he says, oh yes, the virus, and but so is that the way I should be dealing with it? It's sort of like therapeutic lying in a way, but I mean, he's never going to leave there. He doesn't understand that, but
that's
we
right.
know that he's not going to be leaving there because he's in a good place right now. But and this is a pattern over since my mother died. It's, I think, what sort of kicked off I look back now, and he had dementia. Both of them had the startings of dementia even as far back as 2014. And I didn't, until recently, I sort of didn't recognize that fact until, my mother passed away. And that's when my dad really started to go downhill very quickly.
Right.
In 2017.
And that can trigger it. Yeah.
Yeah, that was the trigger, I think, for him. But anyway, I just,
Barb, you're doing the right thing. With my father-in-law, of course, he, in his mind, it was like, well, I need to go back to the farm, because he kept, he was so, 80 some years of his life was, this is where I'm going to die, is at the farm.
Yeah.
And So he kept wanting to go back to the family farm, and we kept saying, well, Dad, you still can't go back there yet. They're not finishing, they're not finished, changing the plumbing and doing this. And we weren't doing anything to the house,
Yeah.
but he didn't understand that. But we told him, like, you just can't live there right now because there's still some work being done. And eventually one morning, Barbara, he got up and he totally forgot about the farm.
Oh, is that right? Yeah.
It was
Because I
just
know my dad's lived in this is the third place he's lived in since he was told, since we, told him that he couldn't go back to the house. I mean,
Right.
that just wasn't, but everywhere he's lived since, he's there for about a year or 2 years, and then he doesn't like this place, he wants to move. And he did move on. He did leave the first place and told us, he's, oh, by the way, I'm moving to this other, and he moved into sort of a, something like the Shannex, Parkland,
Yes.
except it was
Yes.
yeah. And he seemed to be okay there. But then again, he wanted to move, but of course he fell, and then he ended up in this place. But I wasn't surprised to hear him saying that he wanted to move. This isn't sort of a new, but anyway, I just wondered if putting him off the way I do is what I should be doing, or I don't like to tell him the truth, because I just don't think it's, why upset him about something that he, when
Absolutely.
you don't have to.
Absolutely. And with the move, if that were to come up again sometime that he wants to move again, I would maybe ask the questions as to, why do you want to move, Dad? Like, maybe.
He says because he says they're not treating him well there, and he's,
Okay.
which is not true, but I know that. And so
Yeah.
when he starts on about how the food's terrible, he's never liked the food anywhere. So I mean, the food's awful. They don't feed him sometimes, and they don't treat him well. They ignore him, and they don't. I just sort of go, yeah, oh yeah, like I don't respond to it, because
Right.
other than that, so anyway.
Yeah, if you feed into it, it's confirming to him, and then it'll give him more power. Corey made a mention too that it could also be his way of communicating that he's needing connection too.
Yes, I saw that. Yeah, and that's very true.
Distracting him, distracting him with other things that foster the feeling of connection. There's no cooking like home cooking. Let's be real. I get that, but he's probably looking for the salt.
My dad was a 1950s husband who my mother was a stay-at-home mom. She cooked. We only ate everything anything we ate for meals in that house was stuff Dad liked. So I never knew any different. But so he only ate what he liked, and he was an only child, so his mother did the same thing. So now that he's in a place where they're not catering to his specific taste, he's saying, "Oh, the food's awful, and I don't like the food, and they're not, anyway." So I know where that's coming from, but
I definitely hear you. But and that could be what spurs on that all of a sudden I've got to move time, but that
exactly.
That must be very challenging for you guys to be able to find a new place and then to get him moved, where he just goes into the same issues again. So
yeah,
and you could simply say, next time he brings something like that, we're working on it, Dad. We're working.
Okay, and that's sort of what I do. I just say, we'll look into it, or I always say, do you want me to call them and find out what's going on, Dad? And sometimes they say, oh, that'd be great. And I do, and he never asks about it. I know it's
because it's short-term memory, right?
Exactly.
So that's the first part that goes. So he remembers to tell you about it, and then you talk about it, and then he forgets. So I hear all of that. Okay, Corey, maybe there's something about mealtime and food that he felt connection to. Maybe if the wife always made the meals, maybe it's missing companionship of his wife at mealtime. Absolutely. Could be something that simple.
He's never mentioned Mom. He never mentions her, which surprises me, but they were devoted to each other. Yeah. So I know that when she died, that's sort of what triggered his downward slide, so to speak. Yeah.
Yeah, absolutely. He lost his life partner. I look at my mom and dad sometime. We celebrated 60 years for them. I'm going to say 3 years ago. I would say July is to be their 64th wedding anniversary. Wow. And one without the other would be quite lost. Yeah. There's no doubt in my mind one without the other will be quite lost. They laugh together. They laugh at each other. Like Mom says, oh my goodness, getting old is for the birds. And sometimes he'll do things that just, she says, well, if we don't laugh about it, we're going to cry. So we just sit and we laugh at each other with each other. So, but and it's part of life. It's part of
Yeah.
aging, the whole process and everything else. But
Yeah.
and if it gives you any comfort, there was, like I said, that point in time when my father-in-law, just the illness was far enough along that he just forgot about the farm. And
Yeah.
that really was probably one of the most important things in his life,
Yeah.
was that family. He was the 5th generation of boys on that farm, and it meant the world to him.
Mhm.
So yeah, I mean, it just, and that's where we talk about those little white lies, where
Yeah.
telling them the truth will hurt them a lot more. So we
Mhm.
just, we're working on a dad, and then they'll let
Okay.
it go,
Okay.
So I think you're doing great. It sounds like you're doing great. Do
Okay.
you have any siblings up in Ontario around him or near him?
Yes, I have a sister who lives in the same town as he's in.
Perfect.
But of course they're in lockdown,
Yes, of
and so
course.
she's been having difficulty. Obviously can't go in and see him or anything, but
Yeah.
yeah. So she is right there. So he does have
If
But
there's
yeah.
a serious issue or anything, she can run right over. So that's great.
Yeah.
Perfect. There's the Alzheimer link for
Yeah.
Ontario. That might be able to provide some help for you and your sister. And like I said, use the resources that are around us. Oh my gosh, that's why they're there. People work really hard to pull support services and all that kind of stuff together for exactly like situations like this, and they can be so helpful. The
Yeah.
memory cafes, I believe, are perhaps throughout Canada. I think it's like a chain kind of thing. So it might be
Yes.
interesting to maybe look them up, see if there's one in Ontario. Like I don't know where you live in New Brunswick, but like I said, we have one. I know for sure there's one in Sackville, but I think there might be a couple of others
Yeah, I know they have. I think they have memory cafes in I'm in St. John, and yes, they do
Okay.
have them. They do put them on here. Of
There
course,
you
with
go.
COVID, they haven't for a while, but yeah.
Okay.
Anyway, thank you very much.
Super. Thanks for asking the question. Okay, we've got one in Q&A. My mother is in a special care home and has advanced dementia. My visits trigger her confusion and agitation because when I don't visit, she's calm and content. When I want to visit, but don't want to upset her, the home has suggested that I not visit because it's too disruptive for her and it's not good for her physical health to be so agitated. It takes a very long time for the staff to settle her after a visit. I would actually reach out to a support group. I would talk to her doctor or the doctor, your own family doctor, about it. I'd reach out to the Alzheimer Association, to Dementia Association. I would reach out to all of those and see what their recommendations are in regards to that. Yes, and Colleen is saying talk to her doctor for sure, because it may take them a while to agitate her, but it's just as important for you to have that connection with her as it is for her to have that connection with you. Other folks may have experience ideas, or at least can empathize and support you. Absolutely. I think that's really, really important. The first thing to reach out. But I think for me, I would want to be seeing my mom. Maybe not as often. And it'll get to a point where she may not realize who you are, and it may not be so agitating to her, because I did find that with my father-in-law, especially, some of the symptoms that he had would start gradually, and they come to a peak, but then they would slowly start to diminish and kind of pass onto something else. So, maybe 3 months ago was very agitating for her, but maybe if you went now, it wouldn't be so agitating for her. Okay. You could even try sitting in the main room, and if she's able to be up and moving around or in a wheelchair, they could bring her into there and bring her up to your table, and then you could act as if you're just there and not necessarily connected. It's just tough. Yeah, tough stuff. And yeah, like Corey says, having these discussions are so important. So I definitely would reach out to your family practitioner, maybe her doctor, if you can put a call into her doctor, and find out if there are any suggestions or any helpful situations there. maybe talk to the nursing home. What are they doing for some of the other patients that are there? Are they, you know, asking family to not come? I don't know. I find that very sad, very heartbreaking that they're doing that. For me, I would need to go. I would still need to go, but to try to find a way to do it. So good idea. Maybe talk to other people around her first and then connect with her. Yeah. So I don't know. I try some different ideas, but a support group could be very, very helpful for you in this situation. Somebody may be able to relate very well to what you just shared with us. My heart goes out to you. I mean, the illness itself is sad, but to not be able to connect like that, yeah, our hearts go out to you. Our hearts really go out to you. So, any other questions? Is there anything else that anybody wanted to say or to share or to ask about? All right. Well, it sounds like we might be good to shut down. I thank you all so much for your participation today, your questions, your comments, all of that, and then your interest in the topic and wanting to be here for loved ones. I mean, we can't thank you enough for being here to share this with us and allowing us to share with you guys. It's yeah, like Corey says, it's your sharing and your kindness is so awesome. But just the fact that, you know, that part of you still wants to be there for that parent, that loved one. Don't give up on that, but don't forget self-care. So important. Really, really important to all you guys. Practice your self-care. And then, like I said, look for that support. Build that support network around you. That's probably the two top things you should be looking at. Self-care and having that support system around you. So look at putting that in place and moving forward with that, and check for support groups and everything else. If there's anything else, you've got our email addresses, so please reach out. Don't hesitate to reach out, and we'll help you any way we can. You are very, very welcome. So I wish you all a great day, great rest of the week, and take care. Thank you. Thank you.